So coming to our next question about timing of initiation of renal replacement therapy, that has always been a matter of debate. So the exact timing of initiation for better patient outcome is still debatable with conflicting data from various randomized controlled trials. But somehow the early initiation of renal replacement therapy has fallen out of clinical practice. Why is that?
You're addressing a very important question, important for clinical practice. So early or accelerated initiation of renal replacement therapy before patients have an urgent indication is no longer advocated as a result of some landmark randomized controlled trials in the last 8 years. And so with the help of these really important multi-center trials, we've learned that patients who were randomized to early or accelerated renal replacement therapy did not have any benefit, did not have reduced mortality at 60 or 90 days. And furthermore, we've also learned a lot about the potential harm of renal replacement therapy, so diarrheal trauma. And this was in particular emphasized by the START-AKI trial, which showed that patients who were randomized to the accelerated initiation arm had a much higher risk of side effects, much higher risk of hemodynamic instability, and a much higher risk of still being on dialysis at 90 days and being chronically dialysis dependent. So it has emphasized and brought home the fact that renal replacement therapy really is a fantastic therapy for people who are critically ill and have advanced and progressive acute kidney injury. But it is a step up in care and a complex step which has potential side effects. So this is very, very important information. But it needs to be emphasized that these trials were done in a large number of patients with different comorbidities. And it is still possible that individual patients with different particular types of acute kidney injury, hence need for subphenotyping, may well benefit from some early initiation. We just need to find the better markers to indicate timing, the appropriate and optimal timing. Because if you leave it too late, as shown by Acute 2, then the mortality goes up again. So finding the right time where patients benefit from renal replacement therapy without being harmed is still an important task for all of us. And I strongly believe that's where subphenotyping, which we talked about earlier, will help us.
Thank you so much, Dr. Marlies. I think you brought a lot of clarity to that question. Finding the right time is most important in improving the outcomes in deciding the timing of RRT.